2 decades and what has changed in the management of endophthalmitis. Thank you.
Good afternoon. Thank you very much. The Endophthalmitis Vitrectomy Study was organized in the late 80s under the leadership of Bernard Doft and National Eye Institute to find some answers in relation to management of endophthalmitis. 2 treatment randomizations were performed for EVS, and it concluded that the immediate vitrectomy was of substantial benefit if the initial vision was light perception only, and there was no role of systemic antibiotics. Since then, there are many controversies in endophthalmitis management as listed here. To find the answer to this question, it is important to highlight limitations of EVS, new evidences since EVS, and current retina practice trends. So looking at the limitations of EVS, just to give the background of the technology during EVS planning era, it was the time when internet was not launched for commercial use. Apple just introduced Macintosh Classic, and Microsoft was planning to introduce MS-DOS 5. EVS recommendations were only for this group of endophthalmitis, acute bacterial post-operative endophthalmitis, secondary to cataract surgery, or secondary intraocular lens implantation. In other words, it cannot be directly applied to all these subgroups, including new challenges of post-sutureless vitrectomy-related endophthalmitis and intravitreal injection-related endophthalmitis. Even for the early onset cases, it cannot be directly applied to all geographic locations, as there was no single case of fungal endophthalmitis in EVS, comparing with 17% cases reported from India. Eyes with significant opacification of the anterior chamber were excluded from EVS, and because of this, the effect might have shifted the EVS outcomes and its recommendations. For vitreous specimen collection, according to EVS protocol, the vitreous cutter use was at the discretion of a surgeon in TAB group. In my opinion, this is a major flaw of EVS. Nearly 2/3 of patients in TAB group had this procedure performed with an automated vitrectomy instrument. It is very likely that significantly more vitreous was removed from eyes in vitrectomy TAB group than in needle TAB group. Also, selection bias prevented valid outcome analysis, as there was no randomization between needle aspiration versus vitreous cutter use in TAB group. 44 eyes had secondary procedures performed within 7 days of trial entry, but the final recommendations were not based on these events. Only 2 systemic antibiotics were evaluated during EVS, which offered limited intraocular penetration. And the role of intravitreal steroid was not studied, in addition to many other limitations. Looking at the new evidences since EVS, a number of studies, including ours, have shown the benefit of early or primary vitrectomy in managing endophthalmitis, even using 25-gauge instruments. Kuhn and Guinea achieved 20/40 of better vision in 91% of their patients with complete and early vitrectomy, compared with 54% and 52% in 2 rounds of EVS. This series had a cohort of more severe cases than EVS. Looking at the current global retina practice trends, the majority of respondents in the UK and Asia preferred EVS guidelines for all forms of endophthalmitis. It was encouraging to see a changing trend towards primary vitrectomy for post-cataract surgery-related endophthalmitis. So coming back to the issue of controversies, let's have a look why early or primary vitrectomy is a better choice. If you look at the diabetic subgroup of EVS, patients achieve better visual outcomes with immediate vitrectomy, even with initial vision of hand movements or better. The chairman of the EVS accepted that there may be patients who have hand movements or better vision for whom vitrectomy is warranted. In my understanding, if a vitreous biopsy with a vitreous cutter is recommended by the EVS group, and when nearly 2/3 of patients in TAB group had vitreous biopsy with vitreous cutter, why not spend a few more minutes removing more vitreous with the help of advanced surgical technology and techniques? It simply makes sense. The photoreceptors are bathing in this cocktail of toxins, inflammatory mediators, and immunomodulators. It helps to remove the bulk of this material at a very early stage, avoiding irreversible further damage to retina. And there are various additional benefits in managing all other types of endophthalmitis and coexisting complications. We presented our data on speckle domain OCT features in eyes following successful management of endophthalmitis at recent American Society of Retina Specialists annual meeting. We demonstrated that inner retinal changes with a relatively normal outer retina and OCT in all eyes with 20/80 or less vision, and some OCT changes in some eyes which underwent primary vitrectomy and achieved 20/40 or better final vision. These findings additionally support our argument. For surgeons who are little reluctant to induce PVD and performing a complete vitrectomy, a two-stage approach is also a sensible option. As shown here, change in the glow appearance should be the endpoint for stage 1 surgery, but it is madness to worry about development of a new retinal break and not perform vitrectomy at all and allow further damage. The risk of permanent vision impairment is almost always smaller from a retinal break than from infection-related retinal destruction. Experts dealing with endophthalmitis routinely use all sorts of complex approaches to perform early vitrectomy. Timing of the intervention is where the surgeon's error, which is most easily controllable. With correct aggressive approach by an experienced vitreoretinal surgeon who is able and willing to perform the most promising therapy, it is possible to achieve unexpectedly good visual outcomes with primary or early vitrectomy, even in endophthalmitis with virulent organisms and worst possible coexisting pathology. Regarding intravitreal antibiotics, currently intravitreal vancomycin and ceftazidime is a well-accepted combination. William Miller's group reported the role of intravitreal moxifloxacin in cases of drug resistance. Regarding systemic antibiotics, current fourth-generation fluoroquinolones have excellent intraocular penetration rapidly, even when given orally, and it covers the spectrum of organisms we commonly see in all types of endophthalmitis. This has led many experts to routinely use systemic antibiotics. Regarding intravitreal steroids, there are a number of publications assessing pros and cons of its usage. Recent articles have shown the advantage of intravitreal dexamethasone for the management of endophthalmitis. I prefer to use it routinely, except for suspicious cases of fungal endophthalmitis. Benefits of it probably depends upon the timing of administration and organism involved. Kuhn and Beatty routinely use 400 micrograms of dexamethasone for the patients in this study. Looking at the ASRS PET survey 2007, nearly 40% respondents prefer to inject intravitreal steroids primarily. Voriconazole is a better option in managing fungal endophthalmitis. Again, William Miller's group published initial reports of its benefits without any toxicity in cases of resistance to amphotericin and ketoconazole. Regarding prophylaxis of endophthalmitis, a Spirit study showed impressive outcomes with the use of intracameral cefuroxime. This study generated quite a bit of controversy, mainly due to significantly higher incidence of endophthalmitis than the generally accepted norms in the control group. A large number of surgeons across the globe still do not use intracameral antibiotics routinely, and the results of this study must be viewed with caution. It would be wrong to ignore the basic principles of asepsis and sterilization and to think that a magic bullet called cefuroxime can do all the tricks. We proved this point by achieving zero incidence of post-cataract surgery endophthalmitis for consecutive 3 years in nearly 7,000 cataract surgeries. In summary, considering the issues of controversies, here are the changes in endophthalmitis management since EVS, highlighted in yellow fonts. Currently, most experts would prefer this as the best plan to manage endophthalmitis if they develop endophthalmitis in their eyes. A minority group can still be benefited with VGS staff and intravitreal antibiotics with a very close monitoring with immediate vitrectomy option available if required. In conclusion, the organizers of EVS deserve credit for planning the only RCT for the management of acute post-operative endophthalmitis with large number of study subjects required. Any well-performed RCT can have its limitations in supply. Like it or not, EVS recommendations are not the best option to manage endophthalmitis in the current era. Perhaps it's a time for EVS to, with better design, to create new robust evidences and recommendations to manage all types of endophthalmitis. Realistically, it is a very tough task. So, we do not have any option than to rely on the data I presented here from a number of sources to achieve the best possible visual outcomes for our patients suffering from endophthalmitis. I would like to conclude with Ferenc Kuhn's comments. It is unacceptable to simply inject intravenous antibiotics and then claim that everything that possibly could have been done has been done to save your eye, but unfortunately the disease has proven to be too tough to conquer. I think we need to ask ourselves this question in order to find the best management plan for our endophthalmitis patients. I have provided my answer and I hope you found yours. Thank you all very much.
Thank you, Dr. Bhatta, for this nice talk. Now we move our topic because Justice correctly. We'll speak about inflammation and non-inflammatory retinal disease.